Okay, so welcome to Healthcare Improvement Scotland's primary care webinar. My name's Paul Baughan. I'm a GP in Dollar and Clackmannanshire. I'm also a clinical lead with Healthcare Improvement Scotland. In today's webinar, I will be joined by Professor Stewart Mercer, a GP and academic, Laura Kirkland, who is a CTAC nurse educator, Elaine Priest, a practice manager, and Claire Curtis, Senior Improvement Advisor in Healthcare Improvement Scotland, along with Karen Reid, who is a clinical lead for pharmacy. Today's webinar is going to focus on the factors that make a functioning multidisciplinary team. However, before we start, we'll just go over a few housekeeping points. I see most of you found the chat function. It's great to see the range of different people that are joining us today. Please use the chat box to introduce yourselves. And because cameras and microphones have been muted, also use the chat box to post any comments or questions as we go along. My colleague Claire Curtis will be keeping an eye on the chat as she will be leading the Q&A session at the end. Due to the number of people on the webinar, we have muted the mics and turned off cameras. And you'll note that we will be recording the session, but any comments you write into the chat will not be visible on the recording. So, the ambition of the 2018 GMS contract is to enable GPs to work as expert medical generalists and GPNs to work as expert nursing generalists. GPs should have increased capacity to focus on undifferentiated presentations, complex care, and quality in leadership. And one part of this leadership involves leading and being part of an extended multidisciplinary team of primary care professionals. And so it's the MDT component that's the focus of the webinar today. And the definition of an MDT is simply a group of health and care professionals from 2 or more disciplines who provide care for the same patient or group of patients. And Healthcare Improvement Scotland are working with 4 demonstrator sites in Ayrshire and Arran and Borders, Edinburgh City and Shetland, who are all using an improvement approach to develop their MDTs. And we'll hear from a couple of them later in the webinar. We'll also hear from Professor Stewart Mercer from the University of Edinburgh, who has led research into the views of patients, GPs and other primary care professionals about their experience of MDT working. And then we will have a Q&A session at the end of the webinar. So what does general practice MDT look like today? Well, there are certainly a lot more people working in general practice than there were 6 years ago. The circles on the slide represent some of the different professional groups working in general practice today. And it's good to see from the chat that we have representation from most of them this lunchtime. The circles on the left represent staff that are largely employed by GP practices. And in Scotland today, there is around £1 billion a year of funding through the Global Sum, Practice Income Guarantee and Enhanced Services for this purpose. And the circles on the right are largely funded through the Primary Care Improvement Fund, which currently stands at £190 million a year. The numbers in the circles are the most up-to-date full-time equivalent estimates for each professional group. So you can see that the number of full-time equivalent GPs on the top row currently stands at 3,500, and that's been static for a number of years. But there are now over 1,200 full-time equivalent pharmacy staff working in general practice, and they comprise pharmacists, pharmacy techs, pharmacy support workers. We also have over 1,100 CTAC nurses and healthcare assistants, and hundreds of PCIP, ANPs, mental health workers, first contact MSK physios, and community link workers. So within any individual practice, what we would expect to see is these different professional groups coming together and forming a well-functioning multidisciplinary team that grows, that flourishes, and where people can learn together. And research tells us that when and where this happens, patient care is safe, effective, and efficient. For instance, there's evidence around better diabetes management when professionals work well together in an MDT. A well-functioning MDT enables innovation, working together as a team to do things differently and improve care. And a well-functioning team are aware of and support each other's well-being with lower levels of stress, and professionals are empowered and enabled to flourish. Unfortunately, however, not all teams are like that. Just because we have different professionals working in primary care doesn't mean that we've got an effective MDT. Sometimes there are people who never feel part of the team that they're supposed to be in. They feel as if they're on the periphery and not involved in discussions or decisions. Some people initially feel part of their GP team, but then drift away. And sometimes it's unclear if someone is working within the team or working independently. So I'm interested in how functional is the MDT that you're currently a member of. And a poll should appear on your screen or through the chat. And I'd like you to answer this question. If you're a member of more than one MDT, have a think about the main GP MDT that you belong to and indicate on the poll how functional you feel the multidisciplinary team is. So it's quite a range of responses there. Most people feeling that they're sitting somewhere in the middle. So let's consider what needs to be in place to enable an MDT to function well. Research from Professor Michael West and analysis by the King Fund tells us that there are 3 fundamental requirements for effective MDT working, and these are clear and shared objectives, working interdependently, and meeting and communicating. So in terms of the first one, the clear and shared objectives, teams need to understand what they are trying to achieve together. An example of this might be around acute prescribing. The objective may appear to be the same within a GP practice, but they can differ depending on who you are. So a GP receptionist, for instance, may have an objective to help Mrs. McDonald get her acute prescription for her UTI by 4 o'clock this afternoon, because Mrs. McDonald is frail and elderly and can't leave home, but a helpful neighbour has agreed to collect the prescription during the school run this afternoon. Whereas the objective for the pharmacist might be to ensure that each drug on the acute prescription list is prescribed safely, checking that the indications for the drug are clear and that any monitoring or follow-up requirements are adhered to. And the objective for the GP in the practice might simply be to ensure that everyone on the acute prescription list is dealt with before 6 o'clock, so that they've got a chance to get home on time. Each prescription will be considered, but there may not be the time to go into each request in any depth. So you've got 3 different members of staff with 3 slightly different objectives, and you can see how conflict may arise if the team's not open and honest with each other. The second requirement is for teams to work interdependently, and that is that teams must work closely together, coordinating their activity and combining their efforts, and each person trusting and depending on the others in the team to undertake their individual role. So, for example, someone with hypertension may have contact with a CTAC healthcare assistant, the practice nurse, and also at times the GP. And for effective care of that patient, the CTAC healthcare assistant needs to know what to do when a blood pressure is slightly high and when and from whom to seek help when it's at a dangerous level. And a practice nurse prescriber needs to be empowered to titrate or to change antihypertensive medication within a clear framework. And so the GP should be able to trust and depend on both the CTAC healthcare assistant and the practice nurse to monitor and manage people with hypertension, but with the confidence that they'll be contacted for the more complex decisions. And then the third requirement for MDTs to be well functioning is around meetings and good communication. The World Health Organization has identified ineffective communication as a leading cause of inadvertent patient harm. And so a well-functioning GP multidisciplinary team will meet together through regular huddles and team meetings. They'll create a safe environment that allows people to contribute freely and to feel supported when asking difficult questions within the team. They'll use meetings to discuss care and to review performance. And I know myself that if I receive a task in EMIS or perhaps a document workflow in document asking me to do something, it always lands much better when it's from someone that I know or someone that I trust and have chatted over a coffee. And sure enough, research shows that when these three principles are met, teams are more effective and more innovative with lower levels of stress, sick leave, and staff turnover. So one person that has studied MDT working within primary care in Scotland more than most is our next speaker, Professor Stewart Mercer. Stewart is a professor in primary care and multimorbidity at the University of Edinburgh, and he was a GP for almost 30 years. He spent the last 4 years evaluating the 2018 GMS contract and primary care transformation. A large component of this has been looking at the formation and the functioning of general practice multidisciplinary teams. So welcome, Stewart, to the webinar, and thanks for joining us today.
Great, thanks very much, Paul, for that, and thanks for inviting me. I'm delighted to be here. Give the next slide, please. So as Paul said, this what I'm going to talk about today is one part of a program of research that we've been conducting over the last 4 years. It was funded a little bit over £1 million by the independent funding from the Economic and Social Research Council. Sorry. Next slide, please. And I'm not going to go through all the names, but we have a big team of people who did all the work. And I'd particularly like, though, to thank and point out the input of our PPI group. We had quite a large PPI group shown there in red on the right-hand side, and they were involved in all aspects of the research and evaluation, and they were absolutely fantastic. Next slide, please. So Paul mentioned the background to the GP contract, but you know, why do we need a new contract, and what are the challenges facing Scotland? Well, like most countries in the world, we have an aging population, and we have very wide health inequalities. In fact, the widest in Western Europe, and the gap is widening, not narrowing. In both these things, aging and deprivation, patients are characterized by having more than one long-term condition, or multiple long-term conditions of multimorbidity. And as you can see on the graph on the right-hand side, as people get older, everybody gets, just about everyone gets 2 or more conditions, but it's not equally distributed throughout the Scottish population. This is data that we published in the Lancet some years ago. The most deprived group in dark red on the left develop more multimorbidity, and they develop it at a much younger age. So there's a 10 to 15 year gap between the development of multimorbidity in people living in the most deprived areas of Scotland compared with the most affluent, shown in green. Next slide, please. And also, we shouldn't forget that Scotland is a very remote, has a lot of remote and rural areas, and around 16% of the population live in such areas. So they have special, we need to consider their needs in terms of the health and social care systems too. Next slide, please. So our research program was called Scotch. I'm not going to go through in detail everything we've done. We've done lots of different things as shown on this slide. And I'm just picking out some things to show you this afternoon in the time available, particularly relating to MDTs. Next slide, please. So it's always very important to ask patients what they think, in my view. And so we were interested just to know, well, you know, do patients know about the new GP contact? Do they know what's going on? Are they happy to be signposted to MDT staff for first contact care? And what do they think about the care that they get from MDT staff? So next slide, please. So this slide shows the results of a survey we did on just over 1,000 patients. And the patients were selected. Our whole program was based in 3 different health boards. One predominantly, which has a lot of urban deprived people. One health board which has a lot of remote and rural, and one which has a predominantly affluent or mixed urban population. And no prizes for guessing which health boards these might be. And as you can see, in terms of being signposted by reception staff for first contact care to an MDT staff member, most patients were happy. They were either very happy or quite happy in green, which in remote and rural and affluent areas particularly. In deprived areas, well, most 65, 66%, 2/3 were happy enough, but 1/3 of patients were not happy. And we'll come on to that in a bit more detail. Next slide, please. So this is a quote from a patient, 57-year-old patient. If I called the GP with a wrist injury and the reception said, we'll book you into the practice physio, I'd be quite happy. It makes total sense. A GP might have an idea, but their expertise is not in that field, unlike the physio, and it takes the pleasures off the GP. Next slide, please. But the majority of patients that we interviewed, and we interviewed 30 patients across these 3 different health boards, still had the view that they would prefer to see a GP first. So this patient on the left, 76-year-old female, I'd still rather a GP's opinion than any other of the healthcare professionals. I think you should be listened to carefully about your symptoms before you refer to somebody other than the GP. And on the right, an 81-year-old female, seeing other professionals helps the GP, but when you see the GP, they actually know you. They might pick up on not just the ailment, but on your mental health. When care is dotted around different people, some of that gets lost. Next slide, please. Then we asked GPs what they thought, and we did it in 2 ways. We did a survey, a national survey in late 2023, early 2024, of all GPs in Scotland, all qualified GPs in Scotland, and nearly 1,400 GPs responded to that survey. And the survey had many questions, but we included questions about GPs' views on the advantages and any disadvantages of the expansion of MDT and their level of access to different types of MDT staff and the effect on their own workload. And then we did also 20 qualitative interviews in depth with GPs, again, across the 3 different health boards. Next slide, please. So we asked GPs to write down in the survey. It was a paper-based survey. We asked them just to write down if there were any advantages. And 84% of those 1,400 did write comments. And the vast majority of them, 94%, wrote very positive comments about the advantages of MDT staff. And you can see these here. I enjoyed learning from them and supporting them to develop different views on reviewing patients, refreshing ideas. I enjoy MDT work and good to share ideas and expertise. Pharmacists and advanced physiotherapy practitioners are excellent, independently able practitioners who have undoubtedly reduced GP workload in our practice. Huge benefit in reducing strain. Remarkable AMPs, pharmacists and mental health nurses. It's good to have variety in the team. MDT staff have been able to reduce workload, but this has not been able to keep up with demand. Next slide, please. So these are a couple of quotes from GPs. It just feels like certain problems lend themselves really well to being managed by those AHPs as a first point of contact. That's been a really positive change. We have really noticed the difference. And that's a GP in an urban practice which is affluent on mixed deprived population, and a similar GP in a different practice. We're quite far on in having other health professionals in the practice. We've got a physiotherapist, a pharmacist, a physician's assistant. We're signposting through reception a lot of our patients directly to them at first point of contact. Next slide, please. But the GPs also reported some negatives. So in terms of disadvantages, the need to provide training and support, 60% agreed that was problematic at times. The lack of clinical space within the practice, 68% agreed. And a lack of say over what the MDT staff actually do because the GPs are not their line managers, and 71% agreed with that. Overall, a bit under 50% of the GPs felt that MDT working had significantly reduced their own workload, but that did vary quite a bit by different professional roles and by practice location. Next slide, please. So a couple of quotes. This time from urban deprived GPs working in deprived areas. Am I spending more time as an expert medical journalist? No, because there's nobody that can actually take the work off us. I don't have longer appointment times. Patient demand, it's doubled in the past couple of years since COVID. And another GP working in a deprived area. If we have an AMP and we're told by the HSCP, well, they don't work after 1 o'clock on a Friday, you don't have control over that. But then that's a problem if they're being line managed by somebody else. You're working for two teams. Next slide, please. Okay, what about MDT staff's views? So we interviewed 19 MDT staff across the broad range of the different types of staff that Paul mentioned. And then we analysed the interviews in depth in terms of what the key themes were that were coming up. And we grouped these into intrinsic challenges and extrinsic. So the intrinsic were things like adjusting to the primary care setting. Many of these new MDT staff had moved from secondary care or actually had just qualified. And they found primary care setting quite difficult, very fast-paced and very different from what they had known before. There was the issue of building relationships, which are crucial. The training and development needs. The line management issue came up from the MDT staff themselves. And the need for monitoring and evaluation, which they felt wasn't happening sufficiently. The extrinsic challenges, of course, the pandemic. I mean, it's been huge. And the new contract started in April 2018. And then, of course, the pandemic hit a couple of years later. Time pressures, everyone's busy. Hybrid working using remote or telephone consultations. Some problems, not just GPs reporting that, but MDT staff. Staff morale was felt to be very low in some places. Post-COVID, everyone's still tired and busy and recovering. The issue of GP workload, many of the MDT staff themselves said that GP workload wasn't reduced. Some said that it was, so it was very mixed. And health inequalities. And nobody we interviewed felt that the new contract and the expansion of the MDT staff had reduced health inequalities, but mainly people just didn't know. Next slide, please. So a couple of quotes. Coming from secondary care into the community, for me, was very difficult. The differences are absolutely huge. It's a completely different mindset. You don't have the answers in front of you. It's navigating the hospital without walls. Loneliness is an issue. It's a very independent role. You're the sole decision maker. You're not on a ward round. You're in somebody's house or sitting in a clinic room on your own. And that was our ANP in an urban, mixed, affluent, deprived area. On the other hand, this advanced physio practitioner in a different practice, again in a similar type of area, said, I think our MDT roles are very well supported here. I speak to the GPs regularly. They are very approachable. It makes me feel very much part of the team. It's been welcoming and very supportive. Next slide, please. Another couple of quotes. More support is desperately needed for staff as they roll out. They're thrown into these roles. If I was to stand up in a court of law, can you justify why you did this and that, and what training you've had to do this? I'd be a little bit concerned. And this was a very experienced, advanced physio practitioner working in a deprived area. And the second quote from a remote and rural practice, first contact physio, enough time I very rarely get a lunch break, and I'm always late after work. So no, definitely, no, you're always looking at the clock. And it's quite clinical based at the moment because everyone's just under pressure. Next slide, please. So to summarize, well, I think it depends if your glass is half full or half empty, how you perceive things. It's certainly not all bad news, and it certainly isn't all good news. It's mixed. So patients are open to MDT staff, but they still want to see their own GP, and they've very much emphasized the desire to see their GP and have continuity of care with that GP and not just any GP, something that's become quite difficult over recent years. Secondly, the GPs felt there were many, many positive things about the MDT expansion, but there are some negatives. And the MDT staff themselves, many of them report excellent working practices and integration, but others struggle with things like the fast pace of general practice, training, relationship building, and so on and so forth. And the general message, of course, is that everyone is too busy. My conclusions are that the rapid expansion of the MDT team has been welcome, but I think there's a need for planning and support to improve as we go forward. There's no indication nationally of reduction in GP workload from the data we've got, but we do need more data on this, hard data, in terms of actual workload and numbers of consultations and so on. And we are looking at that at the moment, but I don't have any results yet. And I think we do need to pay more attention to those patients with complex needs, the multimorbid patients who are older or those living in deprived areas, because otherwise the new contract may serve to widen inequalities rather than reduce them if the contract is working better in the more affluent areas than in the most deprived. And that's certainly the message we've had. But again, we need hard data to actually be able to see if that's the case or not. Next slide, please. So all of this work's been published. It's all open access. Next slide. So if you can't sleep or anything, then feel free to look this up, and you'll be dozing off pretty soon, I'm sure. Next slide. Thank you.
Thanks, Stewart. Clearly a wealth of information there, from your survey of patients, GPs and MDT staff. I'm struck by the range of views, with some people and some teams appearing to function well, and yet at the same time examples, where MDTs have either not developed sufficiently or where they're adding additional workload to practices. There are some questions, Stewart, that were submitted ahead of the webinar, and I can see through the chat that there's quite a few questions coming in just now. So if you have a question for Stewart or about the wider aspects of MDT working, can you please pop them into the chat over the next 5 or 10 minutes? My colleague Claire is going to theme the questions, and then we'll have a dedicated Q&A session later in the webinar with Stewart. Before that, the next part of this agenda is called a sofa session, or a virtual sofa session. And it's an opportunity to explore some of what we've heard from Stewart with a practice manager and a CTAC nurse lead. I mentioned at the start that Healthcare Improvement Scotland is working with 4 demonstrator sites as part of the phased investment programme. I'm delighted to welcome both Elaine Priest and Laura Kirkland, who are part of this programme. Elaine is a practice manager at Burraloch Medical Practice in Edinburgh, which is a large team looking after around 11 or 12,000 patients. And Laura is a nurse who qualified, I think, during COVID, but for the past 2 years, Laura has been working as a primary care educator for CTAC in East Ayrshire. So welcome, Elaine and Laura. And Laura, I might start with you. Stewart highlighted some of the challenges to multidisciplinary team working, including GP practices feeling that they're not being in control of the work that the staff do. And, we know from the research that having a clear role and shared objectives is important. I just wondered if you could say a little bit about how you have developed a clear service specification for CTAC in East Ayrshire and what the benefits of that have been.
Yeah, so in Ayrshire there was a lot of work done with a lot of stakeholders, including GPs, primary care, board members were involved in these workshops, and it was agreed that we would work to, this specification was produced, it was agreed that we would be a GP-based model initially to ensure a smooth transition for the patients, and that supports the primary care improvement plan. But what the spec means for us and for GP staff, other MDT colleagues, is it gives them a clear understanding of what we are there to provide, what timescales we're going to work to, and it also highlights what we require from general practice colleagues to implement our service, and helps to kind of reduce any sort of grey areas because it's very clear on our role within the multidisciplinary team.
That's really helpful, Laura. And who was involved in drawing up the service specification?
It was produced by the primary care lead nurse, but all the stakeholders were involved, such as the general practice, other primary care members and board members as well, and the clinical team leads were involved in it as well.
And Elaine, maybe from your perspective as a practice manager, how do you ensure that the role and the objectives are clear when new MDT staff join your team in Edinburgh?
Well, sometimes whenever there's a clear need, getting involved in actually the recruitment stage has always been quite useful, but it's not always guaranteed that you'd actually get that opportunity. So in essence, there's always been a bit of whenever someone's been line managed out of the practice, it can be seen as quite a frustration. But for me, it's always been about involving the line manager in any meetings and actually breaking down those communications, because sometimes the position of what a colleague is coming in to do and what they actually believe or what the practice actually require, sometimes differs slightly. So it's about breaking down to see how much of leeway can be given either way and how much comfort can be taken so that we are getting the most out of the MDT colleague whilst meeting some of the practice needs.
And do you find that there is a bit of give and take? If there is, you mentioned a bit of leeway. Do you find that you are able to negotiate a little bit about how you use that member of staff within your practice?
In the main, yes, and that just comes down to conversations. There's no point trying to build up a hostile environment, which is uncomfortable for everybody. And there you have a colleague with you, and you've got clear needs. So yeah, it's the communication that is so key, and having those open conversations and actually involving the MDT colleagues, so that they know where they fit into the practice and how their practice runs. And as we know, every practice runs differently. So it is about spending that time and investing in that individual so that they feel very much part of the team, that, regardless of how they're line managed, it's not an obstacle to how they work in the practice.
That's great. And Laura, Stewart highlighted that many MDT staff find the transition into general practice difficult. He highlighted that sometimes it's a faster pace, sometimes people are working on their own at times. Is that something that you've encountered within the CTAC team, and what have you done to try and reduce the impact of that?
So yeah, it's definitely something we've came across, but we do things to minimise it. So in Ayrshire, we had quite a rapid growth in our CTAC team. It went from around 9 whole-time equivalents to 90 within the space of a few years, and it was recognised that the GP staff can sustain the staff training. So that's where my role with the primary care educator was introduced. So that allows me and my colleagues to take some of the pressures off the GP staff. We oversee and implement all the training to ensure the staff can fully deliver this CTAC spec and offer an equitable service across all the GP practices in Ayrshire, and it's been quite successful. And our staff themselves, they share all their learning with GP colleagues as well.
And if you have a new member of staff that's going to be going into general practice for the first time, what do you do to help enable a smooth induction into that GP practice?
So we keep open lines of communication with the practice managers of the staff that are coming in, but from the staff's perspective, we have an induction pack that has curricular checklist of what introduces the staff to the NHS, the CTAC team, but also lets them know what we require from the practice, such as inductions to the staff, the building, fire exits, things like that. But we've recognised that we can't have like a one-size-fit-all inductions because all the practices do work very differently. So we have things like practice profiles that we worked with our existing staff and the practice managers to produce a document that's individual to each practice. It includes things like escalation processes, location of equipment, contact details, so they're well prepared when they go in. We've got the primary care educators there to support the staff and to support the general practice with induction and with all staff. We have supported learning plans. We include our appraisals and induction. We've got a programme called A-Grant, which is an evidence-based practice learning resource that supports the delivery of all the interventions that we do and ensures holistic care. And we give the staff protected learning time to complete this. It was developed for newly qualified, but we use it with all staff to ensure there's no gaps in their learning and they can deliver the role. And we also, right from the start with our staff, introduce them to a restorative supervision programme to bring the staff together and support them for reflective practice, which has been a good success.
And you mentioned that there's not one size that fits all, and I'm sure you get feedback from CTAC staff about different experiences in different practices within East Ayrshire. What are some of the things that you would say that practices themselves could do that would ensure that new staff joining their team are, feel welcomed and feel able to contribute fully?
So we asked them to support our staff induction, asked them to include them in nurse meetings, practice meetings, asked them to have an open door policy for support for staff. Even though we are there, we do recognise that sometimes they will need clinical, especially clinical and non-clinical support from the practices. Just give them the induction that they would give their own staff. And we're quite fortunate in Ayrshire that most of our staff have had good experiences.
That's great. And Elaine, from your point of view, on the other side, as a practice manager, when you have new staff that are joining your team in Burlough, what do you do to help them feel welcome and help them with a good induction?
So a lot of the things that Laura mentioned in the respect of open door policy, but one of the things for also about good relationships with their line manager, so that they know that there's a good relationship there, that everyone sings from the same hymn sheet. We're fortunate enough to have MDT space in our practice, and therefore they're very much involved in that, working in that MDT space, and then the inclusion of them within meetings, and even simple things like lunch breaks, Christmas dues, so that they can actually see that they're very much part of the team, working with the mind of looking after our patients.
That's really helpful. And you mentioned meeting. Do you make time to meet as a team, and if so, how do you go about that?
So we do. We have weekly multidisciplinary team meetings, of which I facilitate the agenda. It's a 45-minute meeting every Wednesday. The agenda is set in advance, if you like, and it's aimed towards sharing the risk of complex patients, but patient continuity of care, and working as a team and sharing the risk, I suppose, of looking after patients with continuity of care. So we have, as I say, a set agenda. It is a sacrifice of time, but it's well worth it because everyone gets to air, and it also gives, from my point of view, an opportunity to discuss any changes in protocols or processes openly and inclusively, so that any changes can be discussed and then they can be reeled out to everyone else so that everyone's very clear.
Okay, and I'm sure there are people that are on this webinar that are thinking, we're just under so much pressure. There is no way that we could free up 45 minutes, to have a meeting with our MDT staff. How did you manage to persuade the GPs in your practice and the other people in your practice that this was a valuable use of time?
Well, to be fair, the proof is in the pudding, so to speak. So they've actually seen it, and anyone that's actually attended one of our MDT meetings has actually seen the open benefit of it, which it has been, it's a relief for some of the MDT whenever they're particularly struggling with a patient. And, you may only have the one physio in your practice who may feel that they don't have enough peer support within the practice because there's only one of them. So, it is about working together to ensure that they feel that they are adequately advised to deal with patients, or indeed for support for transferring that care, so that it's not transitional, because there's an awful lot in the press about how it's transitional GP in these days, and to a certain extent I suppose that is true, but for your complex patients you can't really allow that, because the time that's spent whenever they're coming in to see repeat GP appointments and taking up from GP appointments, it's actually taking a step back and seeing what your need is in the practice and aligning that care package with your patients.
That's really helpful. Laura, from your perspective, is there anything else that you feel contributes to good team working?
Yes, so I mean, we know from studies and research what makes good MDT working and how we should induct new staff, but it's from the feedback we've had from staff, it's small gestures that aren't necessarily expected that really make the difference and make the staff feel part of the team. Being able to use the milk, being able to park in the car park if possible, as Elaine said, being included in social events, being made to feel welcome in the staff room and included in conversations to build good informal relationships with other staff. We find that's what really makes the difference to our staff.
Yeah, Elaine, and from your perspective?
Yeah, it's to a certain extent mirroring what Laura said. Though it's not a visible line, is it? Whenever they're working in a practice or seeing patients, and therefore, to build up obstacles to that transition and not for it to be beneficial so that it doesn't work is really unhelpful and huge implications on time, which whenever they don't come to anything. So it's in everyone's best interest to actually try and make that work and get to know that individual and what makes them tick and what they're interested in, and seeing if you actually can align your objectives.
That's really helpful. And any final thoughts from either of you before we head into the sort of Q&A session? Anything else that you'd like to add about, what makes a good multidisciplinary team from your perspective? That's fine. But thank you very much. It's been really helpful getting your reflections and from you, for your practical tips and suggestions. I'm conscious that there's, I'm keeping an eye on the chat, and it seems to be there's quite a lot of different things that have come in. I've not been able to read them all in depth, but one person that has been is my colleague Claire Curtis. And so I think we'll just head straight into the last part of this webinar, which is really to address some of the questions within the Q&A, and I'll invite back Stewart Mercer and my colleague Karen Reid and hand over to Claire to take forward this last part of the session.
Thanks, Paul. Hi, everyone. Safe to say there's a lot of activity in the chat, which is fantastic, and our prediction about we might not get to answer all of the questions today has definitely come true, because I think there's probably about 50 questions and reflections at the moment, which is fantastic. But there's quite a few specific ones for yourself, Stewart. Apologies, I can't see you on the screen at the moment, but I'm hoping you're there as well. You are. I've just seen you've come back on the screen. That's great. Thank you. So I don't know, Stuart, we've sent them to you separately. I don't know if there's any you want to maybe take from your list that you want specifically to answer. I don't know if you've had the email chat yet. I don't want to block up the chat box too much with them.
Just in the chat box?
I think they've been emailed to you.
Oh, they've been emailed to me. Okay.
Yes, apologies. We realised you hadn't got the chat.
Sorry.
I think maybe while we're doing that, Paul, is there anything that you would maybe want to speak about your general reflections before Stuart comes back in with some of his, and we can give Stuart a couple of moments?
Yeah, and one of the questions that came in earlier was around that relational continuity of care. And I think that is really important. I think a cornerstone of general practice is about that ongoing professional relationship between the doctor and the patient. And there's clearly evidence of improved outcomes where there is continuity of care, particularly longitudinal relational continuity of care. So I think there is a risk that relational continuity of care may be affected by more multidisciplinary team members. But equally, I think there are also ways to mitigate against it. I think looking at appointment systems that allow people to book routine appointments with a health professional of their choice, rather than simply dealing only with urgent on-the-day problems. I think it's also possible to have conditional continuity of care with an MDT member where, someone may see the practice nurse for management of their COPD or their mental health nurse for anxiety, but they'll see their GP for their other multi-morbidity and, issues around the general health. And where these people are communicating well together through, either through meetings or through accurate and up-to-date clinical notes that are shared and accessible, then it's possible to have that. It's possible to have a degree of continuity of care within a team. I think you're on mute, Claire.
Managed to mute myself there. Thank you. Stuart, is there anything you want to add to that question before I come back to your questions from your presentation?
No, I think Paul's covered it. So I've just got the email. So yeah, there's a lot of questions. Don't think we'll get through them all. Do you want me to?
If you maybe just want to pick 2 or 3, and we'll make sure that the other specific ones are done from the Q&A.
So
we'll have an output.
There's questions about, are these findings age specific? So I'll just open the email again to see exactly what it said. Is there an age gradient to patients preferring to see a GP? Does SMD or reality make a difference? And so on. So in terms of the preference to see a GP, that was on the qualitative work. So that was with interviews with 30 patients. And we sort of deliberately oversampled patients who had multimorbidity. We had about 2 to 1 because we wanted to find out about the sort of complex patients' needs, which was actually one of the aims of the funding. So yeah, I mean, there is as far as I can answer that, yeah, there is a degree of age gradient. I mean, I think patients with complex multimorbidity, tend to have a relationship with a GP or a few GPs, and they particularly feel the need for the GP input. So, and because multimorbidity, as I showed on my second slide, I think, is age-related, then of course those patients tend to be older. Younger patients with single conditions, long-term conditions, or no long-term conditions, it's not such a burning issue, unless they've got some really complex issue going on, such as severe and enduring mental illness. Then again, they want to see the GP they know and trust, and so on. So, yeah, I mean, I think it's particularly important for any patient who's got complex needs, which would, be a mixture of multiple physical conditions, mental health conditions, and in deprived areas, of course, social problems that all just feed in to the consultation when patients commonly come along with like undifferentiated problems. They don't really know how to make sense of it all, and that's what GPs are expert in. That's why we're expert medical journalists. There's a question about why didn't I do a survey of the MDT staff? I mean, I think, well, there's 3 reasons. The funding was largely to have a sort of GP focus around the extension of the team, the cluster working, and so on. Secondly, there's not a list, or at least there wasn't a list available all the MDT staff in terms of their names and where they work. So I didn't have a denominator. Whereas for GPs, that information is publicly available on Public Health Scotland's website. And thirdly, we were keeping in close contact with Healthcare Improvement Scotland, and they did their own survey of MDT staff around the same time as our work. And actually, they found very similar findings. So we thought there wasn't any point of duplication. But I agree, it looks like an omission on our part. But we did think about it. But we thought Public Health Scotland had covered that. Had covered that. Now, there's a question about physician associates. We didn't drill down into that. We only interviewed one. I know it's a very controversial issue at the moment, particularly in England. The numbers in Scotland are quite small, I understand. I think I got told recently about 100 and something. So, yeah, I don't have a particular view on that. We didn't collect any data. Other questions that were they? Yeah, well, there's a question here about my GP and can that be eradicated? Well, I hope not, because as a GP, as a doctor, it's one of the best things about general practice, and we know there's very, very good evidence that relational continuity, and the data is mainly on GPs, is very good for patients' health. It's the only intervention we know of that reduces hospital admissions and reduces mortality in patients with multimorbidity. So I think continuity is really important, and particularly for those patients with complex multimorbidity. And I think the degree to which MDT staff can give relational continuity very much depends on the patient and the staff member. And a mental health nurse or a link worker may give actually very good continuity, and it may be episodic, but then the patient might come back 2 years later and see the same link worker. So I don't think it's just with the domain of the GP. I do think it's an issue of the potential fragmentation of care as the team expands. And I think, as Elaine alluded to, some of that can be circumvented by having MDT meetings where the patient's actually at the center of the discussions. There's good informational continuity, and the patient begins to feel they're being looked after by a team. And I think that works in many places. It's more difficult with very big practices, and in some places, like in the USA, they're doing a lot of research on micro teams, where you have a certain group of MDT staff and a GP looking after a certain number of patients, and they try to keep continuity there. So, but I think continuity is one of the most important things facing the future of gender practice in the NHS. Will I keep going, Claire, or do you want to come in?
No, I think we've got some other ones coming in as well, Stuart. So if you're okay, I will move on to them and we could do that.
Right.
I'm going to maybe just check in with Karen Reid, my colleague, about from pharmacotherapy perspective, if there's anything you want to add about continuity, Karen?
I see a lot of continuity care, needs to have excellent MDT working, and I see a lot of chat and concerns in the chat about the increasing need because of space and premises for hub working and how that affects the MDT, and it will have a knock-on effect, and it's hard to see how we can overcome that if there's not enough room in the actual physical building of the GP practice. But I think how some have come around that is that you have teams that are just not solely working in the hub. There's a rotation of you work in the practice and then you work in the hub, and you can get an understanding of the MDT themes going on through the practice as well, and then bring that knowledge into the environment of the hub. So you're not really working in isolation. You understand the MDT principles within the practice. That's all I can think to add from the questions from the chat. And there's another theme came through about conflicting priorities for the HSCP, and in the current financial climate, pharmacists have a role to deliver efficiencies, and that's not going to necessarily save or reduce GP workload, but it is in our remit to try and do that under the current financial climate. So that is a task that we are expected to carry out, and need to carve off time to do that. So that's just another little theme I spotted in the chat. Thanks, Claire.
Great, thank you, Karen. So we'll move on to another pre-submitted question from a GP in Grampian who may be on the call. I'm going to pass this to Paul first of all. How is the operational efficiency and productivity of new services being monitored, and how will this be captured in the analysis? I'll start with you, Paul.
Yeah, Claire, I think that's a really good question. I mean, GPs are generally fast and efficient at undertaking tasks. Dare I say it, sometimes at the expense of cutting corners. New MDT staff often take longer to undertake similar activities, but maybe more thorough in their assessment. And I think that's what is behind this question in terms of the economics of the other MDT staff coming into general practice to do work that GPs traditionally did. So I'd be interested in Karen's thoughts on this after I finish. But one of the things to say is that Healthcare Improvement Scotland is looking at this with the 4 demonstrator sites that we're working with. We're going to be doing that in a variety of ways. We've got an evaluation plan that includes a quantitative, a qualitative, and an economic analysis. Each of the demonstrator sites are going to be undertaking week of care audits, which will quantify activity, both in terms of consultations and non-patient facing work, such as, acute and repeat prescriptions. How long does it take to, complete an acute prescription list? How long does it take to go through, lab results and to look at clinic letters? So the volume of work and the time taken will be recorded for different members of the team, and there will be a more focused economic analysis, working with a small sample of the primary care teams, looking at the type of clinical work undertaken, the member of staff that undertakes that work, and the time taken to complete a particular task. So I think it's a bit of a wait and see. It is something that we're looking at with the demonstrator sites, and I think we'll have a lot more knowledge about that as we get to the end of the phased investment programme.
Karen, did you want to come on?
Yeah, thanks, Paul. I think there will always be, nobody can go through the work as fast as a GP, and therein lies the problem. And I think it's just an appreciation and understanding of the role of the different members of the MDT, and the understanding of why a pharmacist might take longer to do a polypharmacy review, why a pharmacist might take longer to do an acute, and also appreciating that time taken might, in the long run, reduce workload. That we're not getting through the workload as quickly as a GP currently. If a medrec's done appropriately, then that might reduce polypharmacy in the future, because the aspirin's been stopped, and while the apixaban's been started, instead of keeping the patient on the tube because it hasn't been explicitly said stop aspirin. So that is just one example of how I think appropriate medrec might reduce polypharmacy in the long run, and the polypharmacy, in turn, when done thoroughly, will reduce the number of medications, number of repeats, and number of acute requests. And if we take the time to ensure patients understand their medicines, maybe less phone calls, there's a lot of extra activity that might be reduced as a consequence of taking a little bit longer on the task set. And I think if we understand each other's roles, there might be a wee bit more understanding as to why we take a little bit longer.
Thank you, Karen. That's a great point. I've got one for Paul that I'm just adding back into the chat. Apologies, I didn't capture the name. Has the challenge been looked at against the background of fragmentation of the GP career paths? Paul, I don't know, or Stewart either.
I'm just reading it just now. So many new qualified GPs choosing not to take up a partnership full-time commitment. How will this change the impact of continuity of care? So you can still deliver continuity of care without being a partner in the practice, and you can still have continuity of care without being a full-time GP. So it doesn't necessarily follow that there won't be continuity of care without full-time GP partners. However, continuity of care is really important. I mean, there's a huge amount of evidence that is being published, around the benefits to patients, from good continuity of care, both in terms of clinical outcomes and also in terms of use of resources. Where there's good continuity of care, you tend to investigate less. There tends to be less inappropriate investigations, and there tends to be less inappropriate referrals or admissions to hospital. So I think it's a really important thing that we keep our eye on as we are developing MDTs.
Yeah. So I mean, I think I would agree with that, and I think I mean, it's not just the lack of partnerships. I agree with Paul. In our practice, we have salaried GPs who have been there for donkey's years. They provide just as much continuity as any of the partners do. So, but the other aspect is that for at least the last 20 years, governments in England and Scotland have prioritised access over continuity, so being seen quickly. And I think there's a trade-off. You can get quick access, but you can't therefore always have relational continuity with the same GP. And I hope that's being looked at. I know that it's a hot topic in both England and Scotland in government circles, and I hope that's being looked at as part of the phase 2 of the contract. I don't know if it is. I'm not involved at all, but I think we've sort of thrown the baby out with the bathwater when access became the top priority. And again, it's not every patient needs continuity. Those with complex needs, multimorbidity, mental health problems, and so on, are the ones who benefit from it the most, and therefore they're the ones we should prioritise, because the NHS should be at its best when it's needed most, my view.
Thank you all. And there's some absolutely fascinating points. I'm getting very distracted with the chat. Apologies. I'm trying to pick out the right questions. I just really, to sum up, we will definitely make sure we do our best to answer what we can in a Q&A output at the end after today's session. I suppose I'd like one final question for all the panels. If I could ask members, could I ask you all, what is the one thing that you think was the key to success? If you had to pick one thing that you had to nail to a successful MDT working, can I maybe ask you all to say them? I'll start with you, Paul.
I think just good communication, within teams, within the team that you are in. So I think as healthcare professionals, we have advanced communication skills, which we demonstrate on a daily basis with our patients. But sometimes I think we need to double check that we're actively using these advanced communication skills within the team that we're working. Sometimes I see, not in my own practice, but I see in various places and hear from people who, feel they've been blanked, or someone doesn't speak to them, or they go in and, people ignore them. So communication, I think just making sure that you communicate well within the team that you're working.
Brilliant, thank you. And I've realised this is going to get trickier the further down the list we go. So I'm going to pick Laura next.
I think one thing we're quite big on is just remembering about civility within the workplace, and that we're all human here to do a job. Obviously, all the other things that are going to be said, but I think civility is a big thing, and it's something that we promote in the workplace and Sharon anyway.
Thank you, Laura. Elaine.
Yeah, and whilst Paul nicked my communication, I'll go for collaboration, and that really is with those that, you know, in Laura's position, then it would be collaboration with Laura, especially with that individual in mind and how they're settling into the practice.
Brilliant, Elaine, thank you. Karen?
Thanks, Claire. I would say objectives, clear objectives, and objectives that have been jointly discussed with the lead. If you have a lead in the HSCP and you're providing a service to the practice, and that member of your team is going to be part of the practice, as Elaine said earlier, setting objectives that meet the practice needs and also the HSCP needs, I think. And to me, the bottom line for any high performing team is trust. Learn to trust the members of the MDT, and in order to do that, take time to understand their role. And I think also it's always good to start with, how are you doing?
Brilliant, thank you, Karen. And that leaves me to Stewart to sum that question up, and then I'll pass back to Paul.
Yeah, I think what everyone said, I think clear roles and responsibilities are very, very important. So everybody knows what they should be doing. The informal stuff, the sharing the milk, they're having a wee chat, these things can't be measured. They're really important. And I think a willingness to be flexible and to change and to work at the relationships, because it only works when you've got the good relationships. And the relationship, it's easy to say it, but relationships sometimes are quite difficult and you have to work at them. And as GPs, you know, we're used to doing that with patients. We have to do it with everyone and vice versa.
Thank you very much. Thank you all. I'll pass back to you now, Paul.
That's great. Thanks, Claire. So I'll just draw the webinar to a close by summarising, you know, some of the key themes that I think we've heard today. The shape of general practice is changing. We've got an additional 5,000 multidisciplinary team staff, largely working across pharmacotherapy, CTAC, and urgent care. Research tells us that we will be more effective at delivering care when there are these three things that are on this slide. You know, clear objectives, clear shared objectives, interdependent working, and good communication opportunities to meet. And, you know, Stewart shared the results of a comprehensive evaluation of MDT working in general practice in Scotland. And that's highlighted both the positive and negative experiences of both patients and staff. And it's been good to hear about what's happening on the ground in East Ayrshire and from a practice in Edinburgh City. You know, I personally think that, you know, whether you're a health board manager, a practice manager, a GP, or another member of the multidisciplinary team, we all have a responsibility to work effectively with our colleagues. You know, there are clearly some complex discussions about the key responsibilities for new MDT staff or ways of working, you know, around centralised hubs or local practice teams. And it's really important that GPs and other stakeholders, you know, are involved in these discussions from the outset and continue to be involved and review working arrangements regularly. But I think, as we've heard at the end, there are so many small but crucially important things that we can all do to improve the effectiveness of our team, you know, such as properly welcoming new staff, you know, introducing ourselves when we join a new team, or when we see someone new in our practice, you know, saying who we are and saying hello, you know, taking time to find out, you know, who people are, what their interests are, organising team huddles or other face-to-face meetings. And if that's not possible, you know, thinking about other ways to ensure good communication within our team. You know, little things, sharing coffee, cakes, biscuits, milk, and social events, making sure that, you know, everyone should be warmly invited to your Halloween fancy dress party this evening. So I think as healthcare professionals, we need to ensure that we're communicating openly and effectively within the teams that we're working, because if we are, and when we do, all the evidence points to better outcomes for both patients and staff. So we have one final poll, which I would like you to complete before you go. And I think there may be something that comes up in the, yeah, good. So there's two questions. First of all, we just want to check, has this webinar improved your awareness of factors that affect MDT working? If you wouldn't mind just clicking on that, it would just be useful for us to check that we've achieved what we were hoping to do. And there's a second question that you can scroll to, which was, how effective has it been in giving you some new ideas for improving your own MDT working? And the results of those questions are coming in. So thank you for your feedback. And there's also a link to a very short, it's going to take less than a minute, survey within the chat. And that asks you to tell us one thing that you might start doing in the next few weeks to improve MDT working in your team. And while you're doing that, I'd just like to finally thank Stewart, Claire, Elaine, Laura, and Karen for your thoughtful contributions, and also to Sarah, Molly, and David, who've been working hard behind the scenes. And thanks to everyone for joining the webinar and for your comments and suggestions in the chat. If we didn't have time to answer your specific question in the webinar, we will do so within the next week and send these out to everyone. And in due course, a recording of the webinar will go on to Healthcare Improvement Scotland's website. So thank you, everyone, and goodbye.